CagriSema can challenge Zepbound, but it has not beaten it. In a direct 84-week trial, CagriSema produced about 23% average weight loss, while Zepbound produced about 25.5% among people who stayed on treatment. That gap matters because CagriSema adds a second appetite signal to semaglutide. It was widely expected to challenge the strongest current weight loss option available today. That result gives Zepbound the lead today. CagriSema still matters because it combines semaglutide with Cagrilintide, creating a different two-hormone strategy that may help people who need another option. CagriSema uses two appetite signals in one weekly injection. Semaglutide reduces hunger and slows stomach emptying. Cagrilintide copies amylin, a hormone released after eating. Amylin helps the brain register fullness earlier and can reduce meal size. Zepbound also uses two signals, but the second pathway is different. Tirzepatide copies two hormone signals called GLP-1 and GIP. Those signals reduce appetite and support insulin responses after food. CagriSema combines GLP-1 activity with amylin activity instead. In simple terms, semaglutide lowers the drive to start eating, while Cagrilintide strengthens the signal to stop. That combination can make meals smaller and hunger less persistent across the week. Zepbound reaches the same goal through a different hormonal pairing. That difference created enormous expectations. Many people assumed that adding amylin to semaglutide would automatically make CagriSema the stronger drug. The clinical results were more complicated. CagriSema clearly improved on semaglutide alone, but Zepbound still produced more weight loss in the direct comparison. The first major result came from a 68-week obesity trial called REDEFINE 1. It compared CagriSema with semaglutide alone, Cagrilintide alone, and placebo. The participants did not have type 2 diabetes. Among people assumed to stay on treatment, CagriSema reduced body weight by 22.7%. Semaglutide alone produced 16.1%. For someone starting at 240 pounds, those averages equal about 54 pounds versus 39 pounds. Adding Cagrilintide created a meaningful improvement. That result established CagriSema as more than a reformulated semaglutide product. It showed that amylin signaling could add substantial weight loss. Even with that added effect, CagriSema still did not match Zepbound under the same trial conditions. REDEFINE 4 tested CagriSema directly against Zepbound. After 84 weeks, estimated weight loss was 23% with CagriSema and 25.5% with Zepbound among people assumed to remain on treatment. Zepbound finished ahead by about 2.5 percentage points. The trial was designed to show that CagriSema was not meaningfully worse than Zepbound. It did not meet that goal. When the analysis included treatment interruptions and discontinuations, weight loss averaged 20.2% with CagriSema and 23.6% with Zepbound. The 2.5-point difference is not trivial. At a starting weight of 240 pounds, it equals about 6 additional pounds on average. That gap does not erase CagriSema's effect, but it gives Zepbound the stronger evidence for maximum average weight loss. CagriSema is stronger than semaglutide alone, but it is not the current weight loss leader. Zepbound produced the better average result in the trial that compared both drugs under the same general conditions. Tolerability also helps explain what patients may experience outside a headline number. In REDEFINE 1, nausea affected 55% of participants, constipation affected 30.7%, and vomiting affected 26.1%. Most events were reported as mild or moderate. At week 68, 57.4% of participants were using the highest CagriSema dose. Investigators could lower or pause dosing for poor tolerance or excessive weight loss. The dose a person can maintain ultimately determines the treatment effect they can receive. Repeated side effects determine whether trial-level weight loss is achievable in daily life. Nausea, vomiting, diarrhea, or constipation can limit food, fluids, and dose increases. A drug cannot deliver its full average effect when side effects repeatedly interrupt treatment or prevent a useful maintenance dose. The clearest practical difference is availability. Zepbound is already available by prescription, while CagriSema remains under Food and Drug Administration review after its December 2025 submission. Approval status changes what patients can do now. Zepbound has established prescribing, dosing, and pharmacy access. CagriSema cannot be prescribed as an approved product while the FDA review continues. Unregulated products sold under similar names are not equivalent to the trial medicine. CagriSema could still fill an important treatment gap. Some people do not respond strongly enough to semaglutide. Others cannot tolerate Zepbound or regain hunger despite using it correctly. A different second pathway may produce a better personal response even when the group average is lower. That possibility should be viewed as an alternative response pattern, not proof that CagriSema is secretly stronger. Trial averages do not decide every individual result. They do set the most reasonable starting expectation before personal response is known. Medical goals can also change the choice. Zepbound is approved for chronic weight management and for adults with obesity and moderate to severe obstructive sleep apnea. Someone with that sleep disorder has an additional reason to choose Zepbound. Type 2 diabetes changes expectations as well. In the 68-week REDEFINE 2 trial, CagriSema produced 15.7% estimated weight loss among people assumed to stay on treatment. That result was lower than the obesity trial without diabetes. The difference is clinically important because patients often compare themselves with the largest number in an advertisement. A person with diabetes, several medications, or limited dose tolerance should expect a different result from a trial involving people without diabetes. Heart protection requires a separate answer. CagriSema lowered blood pressure and improved several risk markers in obesity trials. Those changes are encouraging, but the decisive question is whether the drug reduces heart attacks, strokes, or cardiovascular deaths. A long-term study is testing whether CagriSema prevents those events. Until those results are available, CagriSema should be judged mainly by its proven effects on weight, blood sugar, and other measured risk factors. Proven cardiovascular event reduction remains a separate standard. Access may matter more than a small difference between trial averages. Insurance denial, high cost, or supply interruptions can destroy continuity. A treatment that remains available and tolerable may produce a better real-world result than a stronger drug used inconsistently. Choose an available drug that fits the medical goal, increase the dose only as tolerated, and judge the trend after enough time. Switch strategies when progress remains poor or side effects repeatedly block an effective dose. Once treatment begins, judge the drug by your own trend. Track weight, waist size, hunger control, side effects, food intake, and strength. Do not label treatment a failure during early dose increases, but do not chase higher doses through persistent severe symptoms. Muscle preservation becomes especially important when weight loss approaches 20% or more. Strong appetite suppression can reduce protein and total calories together. Resistance exercise, adequate protein, and periodic strength checks help protect function while body weight falls. That need to protect function becomes even more important if higher dose CagriSema produces stronger appetite suppression. Current studies may improve weight loss by increasing the Cagrilintide component, but they may also increase digestive side effects. New results must show a better balance of weight loss and tolerability. If approved, CagriSema would expand the treatment map with a potent semaglutide amylin option. Its success will depend on reliable access, manageable side effects, and durable results. Patients must also maintain nutrition and strength throughout treatment. Medicine simplified. That's what this channel does. If you want more, hit subscribe. This is not medical advice. Consult your doctor.